The meniscus is a shock-absorbing cartilage in the knee. There are two separate meniscuses within the knee. There's the medial meniscus on the inner part of the knee and the lateral meniscus on the outer part of the knee. Together, they help protect the articular cartilage and provide secondary stability in the knee. The meniscus is one of the most frequently injured structures in the knee. I see this in young athletes, and I see this in people in their 50s and 60s very commonly. Symptoms for a meniscal tear typically consist of pain, sometimes a feeling of locking or catching or popping or clicking in the knee. Sometimes the knee can actually lock and can get stuck in one position. Manipulating the knee or moving it back and forth will sometimes produce a painful pop, and then the knee moves again. That's a classic story for a large, what's called bucket handle tear of the meniscus. Meniscal tears can be treated in different ways. For young active individuals, typically surgery is required. For people who are a little older and less active, many times the pain will gradually go away. If it doesn't, or if it's causing significant symptoms, then we typically are talking about surgical treatment. I compare the meniscus to a fingernail, or a hangnail really. The meniscus, for the most part, doesn't have a good blood supply. Therefore, if the meniscus is torn, it won't heal on its own, and even with surgery, it frequently doesn't heal. So the vast majority of meniscal tears are actually trimmed, just like you'd do if you had a torn fingernail or hangnail. We remove the damaged fragment of the meniscus and smooth down the remainder part so that there's nothing left to catch or snag in the knee. The meniscus is an important structure in the knee. It provides a shock-absorbing cartilage, and so if we can repair it, we like to be able to do that. However, in the majority of people, the tear occurs in an area that doesn't have blood supply. So even if we can successfully sew it back together, it doesn't go on to heal, and therefore there's no reason to go through that. There's a big difference between what we do if we repair it or if we trim it up in terms of how long the recovery is. If we're just going in arthroscopically and trimming up a damaged meniscus, you can walk on it the same day, you can take it easy for a week or two after surgery, but then after a couple weeks you can typically get back to doing all your normal activities. On the other hand, if we do a meniscal repair, it's a much longer recovery. Then you're typically on crutches for up to 6 weeks, and there are significant restrictions in activity for 6 months after surgery. Many times from the MRI findings, we have a pretty good idea of whether we're going to be able to successfully repair the meniscus or whether we're going to need to trim it before we go into surgery. However, I like to have the discussion with each person about the pros and cons of repairing versus trimming it up before surgery, because sometimes we find out that we can actually repair it and we weren't expecting to, or we find that we're not able to repair it and we thought we might be able to. So we keep both options open and do what's most appropriate at the time of surgery.